Hello and welcome to another mini-sode of Bullhorns and Sirens with me, Tommy, and him, Sam. No, wait, with me, Sam, and him, Tommy.
That's it. Me, Sam, and you, Tom. No. It's always our names that we get mixed up on.
Which is
Me,
weird.
Sam. You, Sam.
I'll take it, that'll do. With the two Sams, there we go.
Sams.
So this episode is about to pre or not to pre, and no, we don't mean drink. So we're talking about whether or not we should be pre-alerting our patients versus just taking them in routinely.
That's it, yeah, because we were having a discussion, and I've definitely been to jobs before, and I've worked with someone who said, the hospital queue is really long. I don't think the patient can wait. I wouldn't normally blue them in or pre-alert the patient in, but because the queue is so long, should we? Because those are the things that we've got to be thinking about now when we're conveying our patient to hospital.
Yeah,
How
I guess
long are they going to
the
wait?
state of the NHS is, and we're not getting political here, we're not a political podcast yet. No, and I think that's it, isn't it? Is the state of some hospitals, unfortunately, whether it be due to local pressures, winter pressures, any other pressures that the government can think to put a name to, it's going to make you think, oh, I just want to get the patient in, I just want to get them treated, I don't want them queuing, I don't want them sat there. And then there's also those human factors side of things where you have that sort of like, well, if I pre-alert them, I'm going to be off on time.
Yeah,
And, you get into that mindset as well. But then what you've got to think about when you're looking to pre-alert someone is, you don't want to, first of all, take up a bed from someone else that does need that bed space if it's not an appropriate pre-alert.
100%, yeah, because they might even need to downstep someone in resus to majors
To make space for you.
to allocate space.
Absolutely.
So yeah, there's definitely the bigger picture.
Is there anything you specifically consider when you've got a patient in front of you? What do you base your pre-alert off of?
I think to myself, is the patient do I think this patient will die anytime soon in the next couple of hours? If the answer's yes or I'm not sure, then I'll blue them in.
Okay.
If I'm not sure, when you have those patients in fast AF with a heart rate of 180, they appear pretty well, but I'd still blue that in. But yeah, generally I ask myself.
And I assume you say, you're not just looking at John Smith, who's 20 years old, and not that I know many 20-year-olds called John Smith these days, but John Smith, who's 20 years old and has a hurt finger, and you're not going, well, I might just pre-alert. I'm assuming you're looking at vital signs, news scores, and other sort of history involved with that.
Yeah, 100%. Yeah, so obviously I'll take a set of obs, do my clinical assessment, and then just based on those findings. Also, if when the patient has an underlying condition like COPD, I know that their baseline respiratory rate is going to be increased, and I know that their SATs are probably going to be a bit lower than usual as well. So if there is a pathological cause that I know of their shortness of breath, like COPD, but they seem to be managing quite well with it, then I tend not to blue those patients in, only because they don't need sort of emergency clinical interventions.
If they're coping and it's their normal for them, and you're not there for, say, an exacerbation of COPD, you're there because they've got abdo pain or something like that. Obviously that respirate's normal for them, that SATs is normal for them. We're here for abdo pain, we're not here for their respiratory condition on this day.
Exactly, yeah, that's right. And don't get me wrong, I'll still do a respiratory assessment just to rule it out and everything like that. But yeah, so really I just think to myself, do I think that they are acutely unwell and this is going to cause them to die or rapidly deteriorate? Then I'll blue them in. And the other thing is that I think about is, do they need emergency clinical interventions to save their life that I can't do, that the hospital need to do? If the answer is yes, then I'll blue them in as well. What about you?
Yeah, I think so I tend to sort of think, do you know what do I want for this patient when they get to hospital? Do I think they need to get there because, like, now, and they need to be seen as soon as I walk through those doors, because the treatment is going to, or the intervention or the assessment is going to benefit them immediately? Take, for example, when we pre-alert in stroke patients, the reason we're doing that is because we want the hospital to have their stroke team on standby, and we want them to prepare that CT scanner, because we all know time is tissue, and the sooner and quicker we get them in there, the more chance they have of going back to a normal baseline. So I look at it from that point of view. I think, do you know what are the hospital going to add for this patient when I take them into that resus department. So that's a big factor. You know, do I think it's going to benefit them? Can this patient wait a little bit longer for that intervention? And then obviously I look at other things as well. So I look at, like, you know, vital signs, news scores, the overall sort of history of the patient. And also, you know, how quick have they deteriorated? Have they gone from this is a week's history, you know, or is this actually, this has happened in the last 2 hours and normally they're fit and well, and now all of a sudden they're, you know, noosing in like about 10 and they're breathless and they're tachycardic and, you know, whatever else is going on with them. Instantly I'm going to be like, okay, well, this is a rapid deterioration and they're not getting any better, so they're only going to keep deteriorating more. I need to get this patient in now. It's probably like the factors that I look at. You know, obviously you try and do as much as you can en route for the patient, but we're limited. You know, we can provide treatment, but what we can't provide is assessment. We can't provide the bloods, we can't provide the scans, the x-rays and things like that.
Yeah, exactly. Yeah. So yeah, how quickly does that person need those things as well? That's fairly important. What about traffic? So if you know that there's roadworks, or you just know that there's been a minor ding or a crash on that road that you need to go through, and there's been a build-up of traffic, and you know that the patient's in severe pain, for example, and by travelling on blue lights, you can skip that traffic because it's basically standstill, probably saving a good 15-20 minutes. Would you pre-alert someone because of traffic?
I wouldn't pre-alert them because of traffic. If they were in enough pain and the pain management I was providing wasn't adequate enough, and I thought, well, when I get to hospital, they're still going to be in this level of pain and they're going to need something stronger. And I know that sitting them in a queue, or, you know, keeping them on the back of the ambulance, or, you know, putting them into whatever the rapid triage area is, isn't going to get them that pain relief. Then, yeah, I'd consider pre-alerting them for that reason. I wouldn't pre-alert them because I can manage the pain. I can give them drugs within my scope to sort that pain out, and we can sit in traffic hopefully comfortably whilst that's going on. But if, you know, if I'm not managing their pain with the pain relief I've got, then actually, yeah, I'm going to consider pre-alerting purely based on the medical condition, but not because of the traffic. I mean, if you're asking, would I just like put the blue lights on just to get through traffic, but not actually pre-alert the centre receiving them, just so they're in a sort of place of comfort, safety, I don't know what you want to say, do you know what I mean? It's going to be patient dependent, do you know what I mean?
Yeah, that's it, because I suppose then you have to weigh up the rules of using the blue lights, right? So you got to weigh up, you know, is this an appropriate use of blue lights and sirens?
Absolutely. Can I justify this?
Yeah, that's it. Yeah, so that's fair enough. And to be fair, I feel pretty much the same about that. I think to myself, if this patient needs a clinical intervention quickly, and whether they can wait in traffic or not, doesn't really matter to me.
I think the other thing that I do is I'll discuss it with my crewmate. You know, I'll be like, this is my thoughts, what are you thinking? But I tend to find, and this is the advice I give to colleagues and crewmates that I work with, you know, when they sort of say to me, I'm thinking, should we pre-alert this? I don't know, what do you think? You know, and I always sort of go, well, what's making you think we should pre-alert it? Find out the thought process for that. And I'll ask myself that same question if I'm the one going, should I pre-alert this? And then I tend to sort of go with, do you know what? You thought it, it's come into your head. There's probably a good reason why you thought it. Yeah. Go with your gut, pre-alert it. There's obviously something there that's niggling you enough to make you think, I want this patient to be seen now, not in 2 hours' time.
Yeah, 100%. And also, I would say to technicians and paramedics, and I don't know whether senior paramedics would like to take on this advice, but to be fair, but they do this, is listen to the colleagues that are junior to you, sort of in clinical grade. Because I went to, I think the kid must have been about 2 or 3 years old. They'd had a febrile convulsion. By the time we'd got there, she wasn't having a seizure, she wasn't drowsy, she was watching the TV, she was drinking some water. All of her obs were a bit out of whack, so her rest rate was a bit high, her heart rate was a bit high, she had a temperature, obviously. But yeah, she just looked quite well to me. So I didn't think about pre-alerting her to the hospital. I just thought, yeah, we'll take her in, and the paediatric nurses will probably put her in a cubicle or the waiting room. I don't know. But I was working with a emergency care assistant at the time, and yeah, he's been in the job for I think about 10 months or something like that at the time. And he said, "Oh, are you gonna blue this in?" And I said, "No, I wasn't thinking about it. I think, yeah, all of our obs are a bit out of whack, but she appears quite well. She's not pale, peripherally and centrally. She's she's got a good cap refill time. It was like less than 1 second or something. So yeah, she's not drowsy. She's pretty much her normal self. I mean, yeah, she's unwell, but she's not. I don't think she's critically unwell. And he went, "Oh, I feel really uncomfortable with that. I'd prefer to pre-alert her in. I'm just really worried about this seizure and the fact that all of her obs are a bit out of whack." And I just thought, fair enough. If one of us has got a concern, then that's good enough for me to pre-alert the patient. So we ended up pre-alerting her in, and yeah. They just put the patient into a cubicle. They said, "Don't go to resus, just go to see the paediatric nurse and hand over to her." But even though that the patient wasn't unwell enough for them to think that she needs to go to resus, I still thought that was quite an important thing, because if I didn't listen to him and said, "Yeah, I don't care about what you think. I've been doing this job longer than you, and I'm a higher skill grade than you," then that creates sort of like a bad attitude, really, and also that can become unsafe in the future with other patients.
Yeah, and I think that's interesting. Just picking up on what you said about how the hospital, chose to put that patient in a cubicle or whatever. I think, like, when you get to know your local hospital that you work out of daily, regularly, you sort of know what they do want and what they don't want sort of pre-alerted in. But I always tend to, I don't let that deter me, because we've all got different opinions, different experiences. Yeah. And you shouldn't sort of think, "Oh, do you know what? I've taken one like this in there before, and they were so dismissive. They put them straight into just the triage area." Instead I go, "Do you know what? It's a case by case basis. They might know more than me. They might see this presentation 100 times more than I have. Yeah. But for me, I see this as a pre-alert. I see this as a medical emergency. And I think they need an intervention sooner rather than later." Yeah. One of my friends that's a ED consultant in a very, very big hospital, he has this sort of he's used this to reassure me about things in the past, in terms of discharging patients and bits like that. But he says as in, we've had discussions where I'm like, "Oh, I don't want to discharge the patient." He's like, "Oh, we'll discharge this patient." Yeah. And it's not like I'm arguing with him. We're just learning from one another. And, he's in hospital, I'm pre-hospital. So we have different sort of mindsets and things like that. Also, he's an ED consultant. And I am a measly little paramedic. And so, but yeah, no, he says, what you've got to remember is that we go and see these patients, and we see, maybe, depending on where you work, 5 to 6 patients a day, whereas an ED consultant reviews hundreds of patients in a department in a 12-hour shift. Yeah. And so where this might be your 6th time seeing this presentation, for the ED consultant and the ED reg and people like that, this is their 90th time today that they've seen this presentation. Yeah. And so they're not worried, and you should sort of be reassured by that. But don't ever let it deter you from, what your thoughts are. We're there to learn from one another. And if you come across a good doctor or a good nurse or any other sort of clinician, what they should be doing, if they've got the time for it, is sort of, and if you've got the time to ask them, is being like, "Do you mind me asking why you stepped this patient down? What are your thoughts versus what are my thoughts?" Because that's the only way we'll learn.
Yeah, 100%.
Is by approaching it and going through it with someone that has a different perspective to you.
Yeah, 100%. And I went to this lady, I think she was about 19, and she went into VT the previous month, and she got told if she ever gets palpitations again to call an ambulance, which is fair enough. So she called an ambulance. She had some palpitations, and her heart rate, it was about 125, 130. But she was, again, hemodynamically stable. She had a good blood pressure. She was peripherally sort of well perfused and things like that. So we just took her into A&E normally. We didn't pre-alert her. Obviously, we monitored her on the free lead, and I had her blood pressure cycling every 5 minutes. And if that changed, then I would have pre-alerted her in. But when we got to the hospital, the nurse said, "Oh, actually, do you mind popping her into resus?" And I was like, "Yeah, sweet." And my crewmate was like, "Oh my God, have we done something wrong?" And I was like, No, I think they just want to monitor her. Yeah. And my crewmate went round to the nurse and said, "Oh, should we have pre-alerted that patient?" And they said, "Not really. They didn't really need to get here any quicker. It's only because we need to monitor them, and all of our cubicles that have got monitoring on them are taken up." And
this is it, because we don't know the bigger picture of what's happening inside the hospital with their bed situation and bits like that. Something that we have where I work, and we're very fortunate, I don't know if you have this where you are, but we phone the hospitals direct. We don't go through the operation centre or anything like that. We just phone them from the ambulance, whether we use our landlines or the handsets on the ambulance.
To do the pre-alert.
To do the pre-alert, yeah. But with that, it's quite handy because when you get to, like I said, know your local hospital and regular hospitals. So, like, as well as pre-alerts now, we sort of have this culture where actually we can call and give a courtesy call as opposed to pre-alert and say, listen, this is what I've got. Would you like it in majors? Would you like it in research? I'm just giving you a heads up and bringing it in. They're probably going to need cardiac monitoring, for example, with your girl there that's, the high heart rate.
Yeah.
And it sort of allows for that better working between one another. And often they'll be like, oh, yeah, cool, thanks for letting us know. I'll clear a bed space with a cardiac monitor, bring them via majors or whatever.
Yeah.
And it just sort of, it helps them manage their department a bit better.
Oh, yeah, because then you don't have an ambulance just turning up at your doorstep.
Yeah, this is it. And like walking past and going, by the way, I didn't call you, but this patient, 150 their heart rate. Everyone else is fine though.
Yeah.
Put them in there. So it's getting to know locally, local systems, isn't it? I think is a huge part of do we pre, don't we pre.
Did you know that Bullhorns and Sirens podcast is affiliate members of CPD Me, the most dynamic online personal CPD portfolio going? And we have secured a discount code for all of you listeners. If you just head to our website, www.pocketclinician.co.uk, and you can see on our homepage there'll be a link. Go into CPD Me. Follow that link and type in the discount code Bullhorns CPD and you'll get 50% off your first year's subscription. Enjoy the rest of the episode.
Even when I moved from one ambulance service to another, there are things that previously in the other ambulance service I worked for, they wouldn't tend to blue patients in with this caliber. For example, if you've got some inverted T waves in your ECG, in the original ambulance service I worked for, unless the patient had chest pain and was sweaty, then you blew them in. But if the patient doesn't have any cardiac symptoms but they've got ECG changes, they wouldn't really blue them in. But in the new ambulance service, like it's just been built or something. In the ambulance service that I work for now. I don't know whether this is because of a confidence issue or whether it's because of... I don't know the reason why, but people tend to blue patients in or pre-alert patients that have ECG changes that might indicate ischemia, even though they're asymptomatic.
Oh, okay.
Which I find a bit weird. I mean, I personally don't tend to do it. I know it's for another whole episode or book. I don't know. But
or just...
Yeah. God, I don't know if I could do that. I'd have to do that for 3 hours.
He could so do that.
Yeah. But yeah, so just things like that really. Another thing I was gonna mention is I went to a job where a lady had fallen down 3 steps and fracture dislocated her ankle, and it was obviously dislocated. It was obviously deformed. And I think it's called critical skin, where where it's basically fractured, and you've got part of the like the tibia, basically, or part of the end of the ankle, like really stretching the skin because
so not breaking the skin.
No, so it's not breaking the skin, but it's really sort of right there. It's really stretching it, and you can see basically the bone nearly coming through, but obviously it's not. So yeah. Anyway, we went to this job. We had dosed her up with loads of pain relief. She was fairly comfortable with the pain now, so I think she was marking it about 4 or 5 out of 10. My crewmate, that's it. I was driving, and I said to my crewmate, "Oh, are you pre-alerting this in?" And she went, "No, I wasn't going to." And then I said, "Oh," and it's only because of previous experience where I've been to jobs like that before, and they've gone, "Oh yeah, it's a fracture dislocation. We'll blue them in." That I really sort of thought about it, and I suppose it's to do with, I don't know. You don't know the nerve damage. You don't know if it's going to be ischemic. You don't know what blood vessels are being sort of cut off by that dislocation and fracture. And even now, I don't know whether the hospital do want these patients pre-alerted or not. But apparently, I think that they need to relocate it as soon as possible. I don't know, but they treat that as quite an emergency. Yeah. Even though the patient looks all right because they've got an injury.
Yes, it's an interesting one, like fracture dislocations, because I often, in my mindset, I often think, oh gosh, like that's that's a bad injury. Like, you know, we need to get you in, and I want you seen to as soon as we get. I don't want you sitting in a corridor waiting for a doctor to eventually come and lift the blanket up and go, oh my gosh, what's that? You know, and so
you just hand over a minor ankle
yeah,
injury to the nurse.
rolled on their ankle, maybe a fracture. I'm not sure, mate.
Yeah,
You know,
yeah.
like, so I mean, I had something similar the other day. I had a fracture dislocation of a hip. And, you know, what I've sort of learned to do is it's that, you know, you do your limb assessment, you do your MSK assessment, and you look, you know, is there any vascular compromise? Have they got pulses? Have they got good colour, good circulation? You know, and all those sorts of things. And then patient comfort, you know, I think hips are a little bit different. You know, there's obviously the high mortality rate the longer we leave a hip untreated. And luckily where I work, there's some hospitals that have fantastic pathways for things like that. But even then, I'm much rather take the view of, do you know what? I'd rather pre-alert it and let them know what I've got, for them just to stand at the door and direct me somewhere else. But at least at that point, I've done what I think is right for the patient, and I've done, you know, what I deem to be the best for this patient, and in the hope of directing them towards the best point of care as quick as possible. So I think, you know, that's a big part of it.
Oh yeah, 100%. It's definitely better if you're umming and ahhing about it, or if you've got a patient who's got a nasty injury, but I mean, it's not going to kill them, but they need sort of something done really quick. They need some decent pain relief, and they need that joint sort of putting back in place, or whatever. I think it's called a reduction when they move an ankle. Is it a reduction?
When you like put something back into place, reduce it.
So like a reduction, and they generally will sedate the patient or give them some Penfrox or something, and then put it back. And that's something that they want to do fairly quickly. So I always tend to pre-alert those patients in. I don't know what the bigger sort of idea is across everyone else, but it would be interesting to know.
Yeah, so do you know what? That's fantastic. Drop us a message. What do you do with your fracture dislocations and bits like that? Do you pre-alert? Do you not pre-alert? Do you have specific pathways for things like that? Be great to hear from people.
Yeah, that's it. With paediatric patients, we almost over triage, I suppose, sometimes, and we pre-alert a lot of moderately unwell paediatric patients. And even my local A&E department, they get annoyed with ambulance crews that pre-alert all of these kids.
Yeah, I find like maybe it's because it's that whole, you know, similar to like maternity, mental health, things like that, sort of almost like, well, they are a specialist, and they're not almost, they are a specialism. You know, we don't have enough sort of training, knowledge, sort of exposure, unless you go and do it in your own time about that patient group. And so actually we do panic and we do freak out a little bit more. And there's often times when, you know, I've pre-alerted in pediatric patients that I deem as like, oh, you're not well. And then you walk in and they've just gone, no, just go round to peds. And then you go round to peds and then they're like, yeah, just put them in the waiting room. And you're like, oh, okay.
Yeah,
like,
I thought this kid was dying.
You know, and you're like, oh, okay, what did I do wrong here? And bits like that. And again, the way around that is just chat to them and say, listen, why, what have I, like, what are you seeing that I'm not seeing?
Yeah.
You know, because that's the only way you're going to learn, is just by talking it through with people. You know, and hopefully the people that you're talking it through with are nice enough to sort of give you the time and say, well, actually, this is why, you know, this is what our thoughts are, and this is why we're not so bothered about that. Or, you know, something that I noticed a while back is we have, specifically with my local paediatric department, I'm not sure about other peds departments, but we have a different like age per page of like the vital ranges than what the pediatric departments do. So ours are narrower parameters than what the pediatric, they allow for a wider sort of scope of, like, you know, so say our heart rate for like whatever age is like 120 to 160. The peds department would be 100 to 180. Yeah. And so where I've gone and pre-alerted in someone with a heart rate of 170, they've gone, yeah, that's normal. And I'm like, oh, okay. Is it though?
Because I've done that. Because I've said, oh yeah, their heart rate is out of range, and they've gone, no, they haven't. That's normal. And I'm like, okay, well, we clearly have different parameters.
Yeah, and I think that's like us in the ambulance service and pre-hospitally. I think we're just more risk averse, which is probably why those parameters are different for us.
Oh, 100%. Yeah, I reckon so too. Yeah, so that pretty much sums up us having a good old discussion about to pre or not to pre-drink. No, I'm joking. To pre-alert or not to pre-alert. And I think that, I mean, obviously this is a mini-sode, but I really think that you could talk about every single different thing, different job.
Different condition, and should I pre-alert this, should I not?
Yeah,
absolutely. Let me think. Some good resources for you. So Ash Ice obviously is a good mnemonic to use for your pre-alert. And you can find that in our pocketbook, obviously. A little drop there. But something else that's really good, if you guys don't know about it, have a check out, I believe, I think they're more active on Twitter, now X, than they are on Instagram, in regards to paediatric patients, is a company called Kid Confident, which is run by, I want to say, an anaesthetist with pediatric experience and knowledge. Anyway, they also have paramedics involved with what they do, and they provide lots of just free educational content regarding pre-hospital care for pediatric patients, and their aim is to help us as ambulance clinicians be better in managing pediatrics, basically. So yeah, Kid Confident on Twitter and Instagram, check them out. They're really good at what they do.
Yeah, and another paediatric one is spotting a sick child.
Oh yeah.
And then they also give you a CPD certificate at the end. So that's pretty good.
And don't forget, you've got the nice traffic lights for paediatric patients as well.
Yeah, I feel like this is just a competition now of who can who can reel off the best resources,
jerk out, and no, sorry.
But no, yeah. So there's lots of resources out there, and yeah, I hope that us just talking about it opened up a few thoughts for everyone.
And one last one, sorry, I'm not trying to top trump you. Is talk. Just talk about it. Talk about it with your crewmate. Talk about it with the receiving hospital. Probably not whilst they're trying to do the intervention that you were hoping they would do when you pre-alerted them in, but sometime after that, have a chat with them and say, was that the right thing to do? Would you want me to do that again? Because that's how we learn. I think, that's the most important thing. Never be too ignorant or arrogant to not have that conversation. I think you'll get more respect and more appreciation from colleagues, whether they be junior, senior, to go and actually have those conversations and show that willingness to learn.
Yeah, just want to say massive thanks for listening, and thanks Sam for coming along and staying awake for the episode. It's always handy.
You're gonna make this a thing now where I just sleep for episodes.
Yeah, you started it.
Cool. Stay in touch with us. I don't know. No, that's the wrong thing to say, isn't it? Don't stay in touch, but do stay in touch. Keep listening is what I was gonna say.
Yeah, keep listening. Have some fun. And yeah, you can head over to our website, www.pocketclinician.co.uk. We are getting an array of products for you to buy.
So that's what I was doing. I was setting him up for the plug.
Yeah, that's it. They're all available for you to buy. We've got the Student Paramedic Pocketbook, the ECG Pocketbook, and our newly launched ECG lecture video. It's only £15, which is an absolute bargain. And like I said before, we're going to be adding more videos onto it about ECGs. And if you buy it at this price, then you'll get the extra videos for free, basically. But every time we add a section of videos, then the price will go up. So the earlier you can buy it, the better price you'll get it at. So yeah, head over and get that now. We'll send you a code and a website to go and view it. And yeah, it's a brilliant ECG lecture. The first one is 15 videos, and it goes through things like...
That's basically £1 a video.
It's £1 a video, mate. It's an absolute bargain. Do you know, normal ECG courses like that, they go for like £100 plus. It's mad.
That is mad.
But this one's 15 because we know that all it took for us was a lot of time. And we know that a lot of you guys who are buying it as student paramedics, and you don't have £100 to just
absolutely
flog
not
out on a.
And I mean, on that note, I just want to make a point that everything that we do at the moment, we do it just to put funding back into providing more content for you all. We're not taking salaries from this.
Until you see a Lamborghini on our Instagram. Yeah.
And Tommy's hair has magically grown back.
Yeah, that's it. Yeah. Oh, God, I wish magic could do that. But yeah, so thanks for listening, and just thanks for your support so far. We're really enjoying all of the reviews that we're having and the messages that we receive. So yeah, thank you so much, and enjoy the rest of your day.
Thanks everyone, and we'll be giving you more content soon.
See you later.